So, good evening, everyone. I must thank Dr. Rane and his team for asking me to come and talk to you today about two simple things, that is, gastroesophageal reflux and dyspepsia, and talk about their basic uh, management a little bit more in detail about certain things which we can do before we send the patient to a referral center. So, the upper GI tract has two parts, the esophagus and the stomach, and a small part of the duodenum. So, the diseases of the esophagus are many, but we will be discussing reflux today. And amongst the gastric diseases, we will be discussing dyspepsia, or I would actually restrict more to functional dyspepsia than anything else, because that is the most common disorder that we see in practice and in day to day life. So, the two questions that we are going to deal with are: can gastroesophageal reflux and non-ulcer dyspepsia be diagnosed with history alone? Do all patients need investigations? And can we restrict the investigations and send them to referral centers only and only if some special investigations are required? And can treatment be customized and managed at the physician level? So let us start with this. So my first thing will be about dyspepsia, and popularly we call dyspepsia as indigestion. It means literally hard or difficult digestion. So the patients usually come with pain, they will come with bloat. Sometimes they will have a feeling that they are hungry, but they can eat only half the meal and they suddenly feel full, which is called as early satiety. Now, early satiety in the old age is a little bit of a problem. If that comes, we should be a little careful, and I'll come to that in a minute. So sometimes dyspepsia can also present as heartburn. Previously, we used to say that dyspepsia was only limited to stomach. Now, if patient has some esophageal symptoms, we still call it dyspepsia. So the clinical classification of dyspepsia can be of three types. The first is a structural dyspepsia. That means there is a disease that is visible on our investigations, which could be reflux, it could be peptic ulcer, it could be a gastric cancer. The second, unrelated to gastro, is a non GI causes. So, if a patient comes with sudden onset dyspepsia, is sweating, and is previously either hypertensive or diabetic, then before thinking of a gastroenterology cause, it is better to rule out a cardiac cause. Sometimes an inferior wall MI can come as sudden onset dyspepsia. It can look like dyspepsia. The patients may also have feeling of vomiting and a feeling of slight bloat or urinary urgency. And this is when we suspect that we should not be looking at a gastro cause, but we should be looking at a cardiac cause. The biggest group amongst this is functional dyspepsia. And functional dyspepsia means that whenever you do all the investigations, you are less likely to find an organic cause like a reflux or a peptic ulcer disease. So, what are the symptoms we look at? We look at the frequency, the duration. Why is that important? If it is mild symptoms going on for 25 years, it is more likely to be functional. The patient has a past history of, say, a cardiac illness, has taken multiple NSAIDs, or has recently taken alcohol, then it could be due to the painkillers or the alcohol. More importantly, we look at drug injuries and LMP. Now, why do we ask for the last menstrual period in women? Because quite often, women who become pregnant, in the first few weeks, they may not really manifest the full grade of vomiting, or they have not yet missed a period. So they may only have mild nausea. So therefore, this is very important. Ask them about recent change in diet. If there is, the patient has recently, I find this with young women, recently married, eating out a lot, then go into the in-laws' house where the food is very spicy. They will come back and say that they are intolerant to that food. But then that we have to manage. If the patient is having a lot of tobacco, alcohol, we also look for risk factors of HIV, because that may also come with problems. The other thing, look for drugs. And the drugs that I'm talking about here are the opiates. Patients taking intravenous drugs, they may have different kinds of problems. So that's very important. Lastly, we should also ask about Ayurvedic drugs. It's not that Ayurvedic drugs are bad, but if they are taken for a long time and they are taken in an unindicated case without any physician assessment, then there is likely to be a side effect of these drugs. Okay? So the common diseases in this kind of a patient will be functional dyspepsia and reflux, peptic ulcer. Sometimes a patient with gallstones will come with sudden onset pain. And here you have to do an ultrasound and then check it out. A hernia, a volvulus, or a malignancy. So there's a big range of diseases, and how do we go about it? Now, if a patient has functional dyspepsia, whatever examination you do, there will be very little findings. If there is central tenderness, it's still dyspepsia, it could be a peptic ulcer. If there is sudden onset symptoms, then look for ischemic bowel. If the patient has heartburn, again, you won't find any uh, findings. If the patient has a biliary colic, then the right upper quadrant may be tender. Now, when we look specifically for certain diseases, you may find that in patients with biliary disease or with a pancreatic disease, which can also come with pain, the patient may have anemia icterus. The patient has a GI bleed, he may have hypotension. That's a recent onset bleed, especially if there's a history of NSAID, or the patient is a cardiac disorder where the patient has received a lot of dual antiplatelet drugs. If there is an epigastric mass, it is definitely not functional dyspepsia. An epigastric mass is more suggestive that they may be either a colonic or a gastric mass, sometimes a pancreatic mass. If there is ascites, there's hepatosplenomegaly, HIV-related problems, or an ileus, we know that this is a dyspepsia which is very, very significant, and the patient now needs a lot of investigations. Now, etiology-wise, 70% of patients who come to us have functional dyspepsia. Peptic ulcer disease and reflux esophagitis are there, and gastric cancers are usually in the whole population, there will be only 2 to 5%. However, if the patient has alarm symptoms, which means the patient has anemia, old age, recent onset symptoms, weight loss, then your possibility of finding a malignant lesion increases. And therefore, we should not ignore this diagnosis and say that everything is functional. So what are the guidelines for evaluation? First, determine the cause and find out if there is a structural origin, and then assess whether this is amenable to therapy. Secondly, there are ISAT patients who come with sudden onset symptoms. So then you will investigate these patients completely. Do not leave any investigation out unless you find a diagnosis immediately. So if there is patients who come with suddenly with symptoms and you find that there is anemia, then look for stool examination for occult blood. If the patient has eosinophilia, it is more to look for whether they have duodenal infiltration, and these patients may be intolerant to certain foods, and that is why they have eosinophilia. Next, X-ray chest and abdomen is more useful only in acute symptoms. Ultrasound, I tend to do in all patients who come with dyspepsia, because once in a while I get some findings which I did not suspect, and that may be a gallbladder stone, a pancreatitis which has been there for a long time, but the patient just has mild symptoms, or a lymph nodal mass. And of course, endoscopy is what the gastroenterologist is good at, so they always do that. Now, beyond this, sometimes in a particular diagnosis, we may want to do things like CT scan or MRI based on what diagnosis we find. In functional dyspepsia, these tests don't help. Now, so whom do I do an endoscopy in? Do we do it in all patients? Maybe. But sometimes we want to choose because all patients need not have an endoscopy. So if a patient has new onset dyspepsia beyond the age of 50, the patient has a GI bleed, either it is occult or it is overt. That means the patient comes with hematemesis. Of course, hematemesis is an emergency, and we never want to miss a lesion. If the patient has dysphagia, persistent vomiting, weight loss, and a family history, this is important. If a patient has a family history of gastric or esophageal cancer, please do endoscopic early and tell the gastroenterologist that you are specifically looking for a lesion because this patient has a parent or a sibling who has a gastric or an esophageal cancer. If there is an epigastric mass, of course, and if there is iron deficiency anemia, you will do an upper GI scopy, but sometimes you will even do a colonoscopy to see whether there is bleeding from elsewhere. So what does endoscopy do? It visualizes the lesion. You can do a biopsy, and if there is a bleeder, you can actually do a specific therapy. If endoscopy is negative in a dyspepsia patient, then you are left with only one thing, and that is reassurance. Endoscopy is normal. We have to move to the next step. So what is our approach to management? We have a clinical approach and we go stepwise. So I'm going to show a few cases. So let's say this is a 30-year-old gentleman. Many of you must have seen such patients. Epigastric burning is going on for 2 years. Burning is not every day, it's twice a week. It is mild. It is not really affecting his daily routine. It's aggravated by spicy, oily food. There is no radiation of pain, and the patient has not lost any weight, does not have any anemia. And what investigations would you do? So this patient needs an endoscopy. Maybe the first time you would do an endoscopy, but there is really no point in repeating endoscopy 2, 3, 4 times because it's not going to help. Because the patient then gets frustrated and says, every time it's the same report that comes to me and I never get a finding. So that's the next thing. So now let's say this 40-year-old gentleman. Epigastric burning is not for a very long time. He was started on dual antiplatelets a few months ago. And now his 2 local blood is positive. He has anemia. So I think if I was given case 1 and 2 together and said that you can only do one endoscopy today, I would choose this patient. Because this patient has alarm signs and this patient has anemia, this patient is more likely to have a positive finding. So what would I do? I would look, and here I find that there is a duodenal ulcer. I hope you all can appreciate this lesion here. This is a duodenal ulcer sitting right at the beginning of the duodenum. This is the pylorus here. This is the antrum. So you might find a duodenal ulcer. You might get a report which says only the few erosions and nothing else. But the patient had bleeding. So should you take these erosions seriously? Well, you can decide. And then look for the biopsy for Helicobacter pylori. There should be an RUT taken to check for Helicobacter pylori. And if that is positive, then you can give specific treatment. Now, case 3 is even better. You have a 60-year-old man with epigastric pain for 2 months, mild to moderate, dull aching, as early set, not opening well, and is not accommodating the food that was given to him. So what do? We do an endoscopy here. And when we go into the history again, we see that the patient had weight loss. He also had vomiting, but did not have a GI bleed. So this is a very important subset of patients where, as I said earlier, this is only 2 or 3% of the patients you see. But this is where you will get the maximum yield. And if at all we can help these patients, then these are the patients we can help. So here, this is the ulcer here. There's a large gastric ulcer. This white thing here in the middle is a gastric ulcer. Around it, there is a lot of infiltration. There's edema, infiltration around it. Okay, we take biopsies from here. It's going to show a gastric adenocarcinoma. Okay, so this is this thing. Now, let's say it is type, the first patient that we saw who had symptoms for 20 years, his endoscopy was normal. Somebody else repeated the endoscopy, again normal. Now, what will you do? So, before you do anything, first look at what can happen to these patients. So, there is a Rome Foundation, which is an international foundation, which gives us recommendations of various things. And these are the symptoms. You don't have to look at this, but look at the last bit. No evidence of disease, including upper GI endoscopy, that can explain the symptoms. So if the patient is not on NSAIDs, his H. pylori is negative, he has not lost weight, no anemia, then that bloat, burning is likely to be due to functional diseases where I'll tell you all how to manage. Mainly, these symptoms should be for at least 6 months. And if they are for 6 months or more and the patient does not have alarm symptoms, you can call it functional dyspepsia. So there is a whole lot of pathophysiological abnormalities. Amongst them, some of them are gastric inflammation like H. pylori. Once you eradicate the H. pylori, then it's fine. I told you all about duodenal eosinophilia. Now, duodenal inflammation can be due to allergies, due to food intolerances. And duodenal inflammation actually correlates with atopy. Patients may have asthma, they may have itching after certain foods. Then the second group of problems is that the stomach is not contracting well. Among that, the first one is decreased fundic accommodation. Normally, when we start eating, the gastric fundus starts opening well, accommodates all the food that we eat, and starts emptying it. Now, in patients with functional dyspepsia, sometimes the fundus does not open well. These patients therefore have a bloat that is almost there all the time. Plus, they may have early satiety, but no weight loss. There may be delayed emptying. The antrum is not contracting, so the stomach is not emptying. This happens patients with diabetes. They may have delayed emptying and they keep on saying that they have a bloat. Other factors may be medications and post-infectious factors. So what are the roles of diet here? We assume that some of these patients will respond to diet. Because these patients say that if they have spices, if they have heavy meals, or if they have oily meals, their symptoms worsen. So we presume that if we change the diet, some of their symptoms will improve. And some of them, the symptoms really improve, especially if the patients have intolerance to certain foods. Some patients are intolerant to milk. Some patients are intolerant to peanuts and almonds. So if you take a decent history, ask them. They are intolerant to those foods, and eating them causes a certain problem. Otherwise, we usually say that the patient should avoid spicy, oily, and heavy meals and not eat very late in the night. So, as I said, food intolerance may be associated also with autoimmune disease. And we may be missing the autoimmune disease because the systemic manifestations are not yet there. Another disease that can come with dyspepsia, and if you find anemia, a child who had multiple fractures, the patient is not of adequate height as compared to the parents, suspect celiac disease. Now, one thing to remember is that we were all taught that celiac disease is very common in the north. In the north, in fact, it is almost 1% of the population. Whereas in Maharashtra also, we tend to find a lot of these patients. And the clue is that their symptoms are not going away. And you find that there is anemia, the calcium is low, vitamin D is low. And when you do the specific tests for celiac disease, they come positive. And doing the biopsy will tell us whether there is anything else. The next thing is we blame the gastric acid. Everybody says that epigastric burning, that epigastric bloat is acidity. The patient also calls it acidity and starts taking drugs on his own. So let's see why we do acid suppression. The first is that we presume that acid is responsible for the symptoms. There is an overlap with reflux, and therefore it's possible that some patients who have reflux actually manifest as dyspepsia. So how do we suppress the acid? We know that PPIs are better, and now that the PCABs or the vonoprazan is available, it's even better than PPI. PPI will work best if there are ulcer-like symptoms, which means that the patient has severe pain, the patient has some reason to have an ulcer like NSAIDs or some heredity. And in patients who have H. pylori, the PPI work better. Importantly, at a physician level, if the patient does not respond adequately, don't keep continuing changing the drug, because you will be benefited if you look for another cause. So what are the things that we look at? The first one is H. pylori. It contributes to the pathogenesis of dyspepsia. And if the H. pylori was responsible for the symptoms, then the response rate is at least 20 to 30% of patients will be almost asymptomatic after H. pylori eradication. Also, if patients are going to be on long-term NSAIDs because of arthritis, they are going to be on long-term antiplatelet drugs, then it is better to eradicate the H. pylori. The third set of patients is patients who have a relative who died of a gastric cancer. It is better to eradicate the H. pylori. Of course, in patients who have bleeding from an ulcer, H. pylori has to be compulsorily eradicated. The next group of drugs, I mentioned that the stomach may not be emptying well. So prokinetics have been tried, and there's a long list of prokinetics. You see ecoshiamide, cinetropride, domperidone, etopride. But if you look to the right and you see this graph here, the one that has the maximum efficacy is metoclopramide. For some reason, we tend not to use metoclopramide as much because of the fear of central side effects. Very importantly, let me tell you, prefer to use the single drug rather than a combination with a PPI. The reason is you need the drug at the time that the stomach has to empty, which means you give the drug just before the patient eats or half an hour before the patient eats. The combination drug is going to act for 24 hours. So the symptoms really don't improve much. Some patients improve, so everybody is happy. And if you by chance give a twice a day combination, you're giving twice the dose of the prokinetics. And many of these prokinetics have cardiac side effects. Domperidone has hormonal side effects. The patient can develop galacturia. Mosapride has mild cardiac effects. Levosulpride, which I have not listed here, is a very good drug, but when given to young women, it can cause hormonal changes, galacturia, and a young girl may think that she is pregnant when she actually isn't. And neurologists say that even neurological side effects are very common with levosulpride. Adverse events, again, are high. That is listed here. We're not going into details of that. So the second group of drugs that we can use are drugs that cause fundic relaxation. We mentioned that the fundus has to relax in order to be able to accommodate the food. And the drug that works best there is mirtazapine. It's a psychiatric drug. If you are not familiar with this drug, talk to the psychiatrist, because many of these patients do have underlying depression. The dose of the drug that you use here is 7.5 milligrams, which is much less than what the psychiatric use. So the symptoms really come down. And the symptoms that are important here, if a patient has early satiety and weight loss, mirtazapine works very well in functional dyspepsia. So they gain weight, they tend to tolerate better feeds. The second drug is acoshamide. Now, acoshamide works in the same way as mirtazapine, but it does not have antidepressant properties. Neither does it cause weight gain. But the patients do tolerate the food better. So for dyspepsia, I'll just give you an overall view. If the patient comes with dyspepsia, check whether there is more pain or there is more distress. That means the patient has fullness. If there is more fullness, then prefer to give prokinetics. Of course, everybody will get an acid suppressive drug. Prokinetics and fundus relaxation should be for them. If the patient does not respond, then the patient should have a psychological evaluation and you can go to other therapies. Importantly, if you have diagnosed a functional dyspepsia, most importantly, there is no increase in mortality in these patients because of the functional dyspepsia. Sometimes we may use prokinetics that have cardiogenic side effects, and the patients may have mortality because of those side effects. So it's better to be careful to use very few drugs in these patients. Okay. Now, when there is no response, what do you do? Make sure that you send the patient for an endoscopy and look for a D2 biopsy, because eosinophilia is often missed. Celiac disease is often missed. Also do food intolerance testing for these patients, because that will help. Usually we don't do that on a routine basis. So in patients with functional dyspepsia, first, of course, we will give anti-secretory drugs, prokinetics, but not the combination prokinetics. And if there is adequate relief, it's okay, let them continue their drug. The drugs like proton pump inhibitors are fairly safe. And if the patient is not responding, then we will do things like looking for gastric emptying, fundic pain, and then a fundic tone, and then accordingly treat, and hypersensitivity, antidepressants, etc. So this was the first part of my talk. Do you think we should check questions now? Or should we move to the second talk? Hello? Hello?
Madam, you can move ahead.
Move ahead? Okay, fine. So I'll take the second, this thing. Share, you share. So I'll now come to gastroesophageal reflux disease, which is, by definition, it is a disease where there is heartburn, regurgitation, and the most common manifestation is an esophagitis. We'll go through this quickly in about 20 minutes, and then if there are any questions, we'll take them. Now, what is the prevalence of gastroesophageal reflux disease? It's about 7 to 10% in India, which means almost a lot of patients, not only patients, a lot of colleagues who come to you may be having reflux. The common factor that we see in India that is a risk factor is urban living, non-veg food, fried food, and obesity. So the symptoms are usually heartburn, regurgitation, dysphagia, and water brash. Sometimes patients may have extraesophageal symptoms like asthma, chest pain, hoarseness of voice. But traditionally, we only mention the first four symptoms. So this is the endoscopic spectrum I'm coming back to in a little while. So we'll see that at that time. Now, first of all, natural history. Almost 70 to 80% of the patients who come to us in India don't have any abnormality on endoscopy. So therefore, some of them may be actually having functional GI disease. On the other hand, patients who are fat, more likely to be male, have a hiatus hernia, they are the more common patients with erosive GERD. At the absolute extreme is complications like a peptic stricture, bleeding, and sometimes dysplasia and carcinoma, of 0.25% per year in patients with serious GERD. So therefore, if we will be classifying GERD like that. Now we know that pregnant women, patients with scleroderma, are more likely to develop GERD. If you have seen a patient who had a poem for achalasia cardia, they are likely to develop gastroesophageal reflux in about 20 to 40% of them. So patients with achalasia need to be warned that whatever surgery you may do, especially poem, there will be reflux, which will be a bad complication. So just we'll have two or three case scenarios. There's a 32-year-old with regurgitation, retrosternal burning for 6 months. The patient is slightly obese, BMI of 32.5. CBC is normal, no alarm symptoms, no other systemic features. So we diagnose him as reflux disease because he has classical symptoms and start on proton pump inhibitors. Patient is fine. He goes home, we are happy, patient is happy. So diagnosis is quite often based on typical symptoms. There are people who say that you can fill some questionnaires, but really that is not necessary in day-to-day life. So what is the dose and duration? Usually we will give a PPI for twice a day for 2 weeks. If there is absence or relief of symptoms after 3 days, we are very happy. But sometimes, if the patient is actually not having GERD, he may also respond, so there is no problem. Patients who have no GERD, they also will respond in 1/3 of people. So this may lead to overuse, and that may be a problem. So let us look at the second scenario. Now, this is a more important scenario, and you should always ask for this question. You have a patient who's not fat, 26.8, is just about overweight, on and off heartburn for 2 years. Importantly, this patient has dysphagia. We discussed earlier that there are some alarm symptoms. And for the esophagus, dysphagia is a very, very important alarm symptom. But this patient doesn't have weight loss, no smoking. He started on rabiprazole and still has intermittent symptoms. So in this patient, I would say we would do an endoscopy immediately because the patient has dysphagia. So what is the role of endoscopy in reflux? First is you evaluate whether there are any complications like a stricture or a malignancy. And it is possible that the patient never had reflux in the first place but had something else altogether. Because endoscopy, if it is normal, it doesn't help you at all. If it shows anything, then in that case, the specificity is very high. So indications for immediate endoscopy. So if the patient comes with reflux, as I said, in the first case, we started PPI, patient was well. So we're not worried. But if the patient had alarm symptoms, which we discussed earlier also, that means dysphagia, weight loss, bleed, anemia, elderly person, or progressive symptoms on therapy, severe esophagitis, where we want to know whether there is something else underneath, we will do an endoscopy urgently. So this is the grades of endoscopy, and you see on the left, you see a little bit of these blips, which is very mild disease. On the other hand, on the right side, you see these deep ulcers. And there is also a stricture here, a narrowing here. And beyond that, I see a hiatal hernia. So this is the what you might find on an endoscopy. Severe esophagitis looks like this. The severe esophagitis, there may be bleeding, there may be ulcers. Now, you might find that these kind of findings are not there. But endoscopy, the gastroenterologist may pick up these rings. This is very classical of eosinophilic esophagitis. And as I said, if a patient is symptoms for 2 years not responding, look for the causes. On the other side, on the right side, you see this is candida. And down you find this is viral esophagitis. Sometimes a patient which comes with sudden onset dysphagia, early morning at 7 a.m. he wakes you up. and says, "Doctor, I can't swallow anything since last night." Most importantly, in this case, it is usually a pill esophagitis. Patient has swallowed some tablets without drinking much water. This patient is usually elderly. They like to swallow their tablets at night and go back to sleep immediately. And then they come with severe pill esophagitis. So just endoscopy is done for them and you might find some findings. So take a good history, find out if there is dysphagia, find out if there is chest pain, a recent history of tablets which they may have taken, and take biopsy if the endoscopy looks normal. Now, if the endoscopy was normal and the patient is not responding, so we had one category where the patient responds very well, and a second category where the patient is not responding. Then what do? Then you go to specific testing because endoscopy has not helped us at all. Then you do look at the pH of the esophagus. Before you look at pH of the esophagus, you do a manometry, an esophageal manometry, where we put the catheter into the food pipe. And this is the left graph that you see. You can see the peristalsis. Give a swallow here, and a peristaltic wave comes down. This is the lower esophageal sphincter. This is the upper esophageal sphincter. So this is what manometry is. Now, sometimes you may find that though the patient has come with reflux, more regurgitation, occasionally heartburn, not responding to treatment, you do a manometry, and what you see is that this kind of swallow peristalsis is not here. Secondly, you find that this lower esophageal sphincter, which is supposed to open during swallowing, is not opening. So this is a classical case of achalasia cardia. So this is one of the reasons why you do an esophageal manometry here. Sometimes a patient comes with severe belching. And what you see here is not an ordinary manometry. This is a manometry with what we call as impedance. So the blue is whatever fluid we give to the the purple is whatever fluid we give to the esophagus. The computer colors it purple. And here, what you see is that suddenly the patient has a relaxation of the LES and a lot of fluid comes back. In another situation, you find here that the patient suddenly contracts his diaphragm and a lot of fluid is seen here, which is actually a case of rumination. So in such a case, if you have given PPIs, the patient is not likely to respond. Another mimicker here is this patient is belching. You see this dark blue is actually air. The patient is just contracting his diaphragm and belching multiple times. And here, if you send them for surgery, they are not going to get better. So the next test, as I mentioned, is reflux monitoring. So when do you send a patient for reflux monitoring? First, when the endoscopy was normal. The endoscopy that you got done when the patient had heartburn, it was normal. The second is when the patient has atypical symptoms like laryngeal symptoms or chest pain or asthma. You want to make sure that you want to send this patient for lifelong PPIs. Then in that case, you want to prove that the patient has GERD. And when contemplating a surgery, you will send the patient for a pH metry. So ambulatory pH metry, there is a catheter that goes through the nose and stays in the esophagus for 24 hours. And we interpret it by looking at various parameters, which I will just come to. Okay. So manometry actually does not help in helping in GER, but in case of pH metry, we have a few things to see. So if the patient has severe esophagitis, if the patient has a peptic stricture, you don't need any other investigation to prove that this patient has GERD. But if the patient has low-grade esophagitis, or if the patient has normal endoscopy, then you need to do a pH metry. Secondly, if a patient with severe esophagitis you want to send for surgery, then you need to find out whether this patient needs the surgery or not, and that is why you will do a pH impedance or an HRM. So this is just the way that we look at these patients. So as I said, if the patient has LA grade B and C, and then you want to check the pH metry, if you find these parameters, you don't have to remember these, then you say that this patient has reflux or no reflux. Now let us look at the next scenario continued. This patient had dysphagia and uh, rabeprazole going on for almost 2 years, but there is still intermittent symptoms. So esophagogastroscopy showed a hiatus hernia. There was esophagitis. So now this patient, how will we manage? So there are 4 steps to management, and we'll go through these. The first is lifestyle modification. Second is medical treatment. Now, we will usually start lifestyle modification and medical treatment at the same time. Books will say that first you start lifestyle, but then if you give only lifestyle medication and lifestyle modification and no medication, the patient will probably decide to treat himself. So the first few things that we always tell the patient is stop eating 3 hours before bedtime. Avoid late night meals. Try and reduce weight and get enough sleep, because sleep itself, lack of sleep rather, is responsible for weight gain in certain people. What are the foods that we don't allow? So alcohol, large amount of coffee, spicy foods, carbonated beverages. Carbonated beverages will escape, the carbon dioxide escapes into the esophagus, and the pH of carbonated beverages is almost 2. So the patient will get heartburn after these. Fatty foods we already mentioned. So there is evidence that some of these foods can cause problems. And in some of the other thing that we try is tell the patient to elevate the head end of the bed, have some weight loss, and they may do better. Now, a lot of medical therapy has involved. Initially, we started with antacids. Then the H2 receptor antagonists like ranitidine came. Then PPIs came, and then PCABs have come. So, of course, antacids are there for immediate relief, but the relief doesn't last for more than a few hours. Then you have the histamine receptor antagonists. You have to give them 2 to 3 times a day for reflux. Proton pump inhibitors are now the mainstay. And in patients with grade C and D esophagitis, you would recommend jumping directly to drugs like vonoprazan, fexuprazan, and others. So there are also prokinetics and baclofen. They are only used for refractory cases and daily uses. As I mentioned during dyspepsia talk, we don't encourage too much of these drugs. So symptomatic relief with PPI is almost 80%. And they provide the greatest overall relief. Okay, I'll skip this and come to which PPI is the best. Now, if I look at these, the graph, the table which says the standard doses are pantoprazole 40, lansoprazole 30, omeprazole 20. Now, lansoprazole is safe in children and in pregnancy. That is something very important to remember. Okay. Now, standard doses again here. Liquid preparations of pantoprazole and lansoprazole and esomeprazole are available. And why is this important? For someone who has a stricture and for babies, these are important. But lansoprazole is the one that's approved. IV, these drugs are available. But the efficacy is slightly different. So if I have to choose a PPI, for mild diseases, I will use a pantoprazole or an omeprazole. For severe diseases like severe reflux, a large hiatal hernia, a lot of ulcers, I would tend to use esomeprazole, rabeprazole, or lansoprazole because they are the ones with the maximum efficacy. However, the choice of PPI always depends on indication, the price. Sometimes a drug may be more expensive, and comorbidities. Sometimes you don't want to use rabeprazole, esomeprazole in a pregnant lady because we don't know what's happening right now. Of course, we feel that twice a day healing is the drug is usually better because the PPIs often don't work for 24 hours. They may work for 12 hours. And the twice a day dosing is much better for these patients. The other thing is the dose. As I said, if there is uh, LA grade C or D, initially for 2 months, we would give twice a day. And then maybe as a maintenance dose, we will give once a day dosing. Now, the limitations of PPI. You will notice that many patients, though they are taking the best PPI, the best dose, you find that they are not responding. So, in a patient where there is no esophagitis, the endoscopy was normal, you know that only 40% of patients will respond to PPI. But if a patient has chronic cough, a lot of people for chronic cough think that this cough is due to laryngopharyngeal reflux. And they are given these drugs. And you find that you need to treat 79 patients to get response in one patient, which means that cough in these patients is not because of reflux, but you have to look for other causes, the ENT causes, but rather than pushing everybody to take a PPI and then wait and see what is happening. So in patients with heartburn, esophagitis, erosive esophagitis, or regurgitation, PPIs are fine. But if you take non-cardiac chest pain, chronic cough, and laryngeal symptoms, PPI is not the best answer. As I said, 20 to 30% of patients may not respond, but where there is proven esophagitis, you have to give the drug. Now, main thing with PPIs is they do not address the problem of reflux, which is that the lower esophageal sphincter is damaged. And sometimes we try prokinetics, but prokinetics also do not affect the LES or the esophageal motility. They only cause gastric emptying faster. More than that, they don't do anything. Now, coming to long-term PPIs, patients do ask. So the major long-term PPI, I've listed all of them here, but the major one is a bacterial overgrowth, B12 deficiency, and hypomagnesemia. Otherwise, the rest of them, there are a few cases of acute kidney injury. There will be fundic and polyps, but they're usually harmless. The rest of the causes that I have listed here do not really occur because of PPI. Now let's take this last scenario and finish this uh, talk. There's a 45-year-old man who has erosive GRD. That means we are sure he has GRD. He's having nighttime symptoms of heartburn and a disturbed sleep. So what is wrong with this patient? One, that he has a hiatus hernia. Endoscopy does show mucosal healing, but he still needs the drug. And at one point, he comes and tells you, look, I'm fed up. I have to manage my lifestyle. I can't eat so many things. I can't go to parties. I can't drink. I want to get over all this. I have had enough. I'm not that old also. So what are the treatment options for this patient? First, before we do any treatment options, we would do a manometry to check what is the motility of this esophagus. And if it is a decent motility, we will then tell the patient that you have options of surgery. The surgical options today: choose a good GI surgeon. And anti-reflux surgery, there are three types: Nissen, Toupet, and Belsi. I'm not going into the details of this. There are many other newer surgeries that are coming up, but technically today, Nissens and Toupet are the ones which we most commonly refer the patient for. For patients with mild reflux and no hiatal hernia, a patient may undergo endoscopic uh, modification of the lower esophageal sphincter, but that is still experimental and we are not really using it too much. Of course, patients who are obese, they should have weight loss before they do any of these surgeries. Otherwise, the symptoms will remain and there is no point in doing these surgeries. So overall management of GRD includes lifestyle modifications, including weight loss, diet control, PPIs, maybe prokinetics once in a while. And then if the patient doesn't respond, surgery. If a patient doesn't respond before sending the patient to surgery, and even if you want to continue the long-term PPIs, make sure that you prove the reflux rather than just continuing treatment for years and years together. Thank you. Okay, sir.
Okay. Yeah, thanks. Thank you, madam.
So are there any questions? Hello?
No questions, I think.
Okay, fine. Thank you. Thank you very much.
Thank
Yeah.
you, madam.